Good evening, and welcome to Wednesday Wellness, a free live educational series presented by Trinity Health Medical Group. Thank you for joining us to discuss pelvic prolapse and bladder dysfunction. Before we turn it over to our presenter, we would like to provide a few reminders. Your cameras and sound have been turned off. If you have questions, we encourage you to use the Q&A chat, which is found near the bottom of your screen. Questions will be read aloud and answered by our presenter at the end of the presentation. We are recording tonight's topic, and you will receive an email with the link to the video over the next few days. Without further ado, I would like to introduce Dr. Jonathan Shaw, a urogynecologist at Trinity Health Medical Group.
Thank you for that introduction, and for those at home or in the car or wherever you're listening, I hope you can hear me all right. And please feel free to interact and ask questions, which will be read at the end. I'll try and answer them best I can. My name is Jonathan Shaw, as has been said, and I'm a urogynecologist at Trinity Health. By my accent, you may pick up I'm not from Western Michigan. Been here now for 3 months, and it's a beautiful place to be and to live with my wife and our 4 kids. We have moved around quite a bit. I'm originally from Northern Ireland and did medical school there, and then came to the States in 2010 to Ohio initially, and did an OBGYN residency and then onto a fellowship in urogynecology. That's one of the ways to end up doing this. The other way is to do urology as a residency and then to do urogynecology after that. We lived in Kenya for a couple of years at a mission hospital and then moved back to New Hampshire, where we were for 5 years. And now we're here and hoping to stop moving around for our kids' sakes and for our own sanity, and happy to be here working with Trinity Health. The topic tonight is, of course, pelvic prolapse and bladder. And it's a pretty broad topic, even though it sounds quite specific. But what I will do is just give a brief overview initially of what urogynecology is all about, and then we can go from there. So urogynecology is this interesting connection between urology and gynecology, and the areas do focus on bladder issues, prolapse of the pelvic organs, bowel troubles, really just the last couple of inches of the bowel, rectal troubles, and sexual function or dysfunction, because a lot of these issues overlap with that. I do get the question fairly frequently why I ended up in this area, and I'll briefly tell you, it started with being interested in obstetrics. I loved emergencies at one time. I loved the labor and delivery and the bringing of new life into the world, and that mixed with a trip to the third world where I saw women sadly die during childbirth, just seeking to be moms, had a big impact on me. And then I went into this field, and as a resident in OBGYN, got drawn more to the surgical side of OBGYN. And this, in particular, this field, which I'm happy to say starts with sad stories, but ends up being happy for most of my patients. So who wouldn't want to do that? It may not be the most glamorous occupation, but I'm happy that my patients are happy after they've seen me and we've been able to work on something together to make things better. And by the way, I'm still involved with Third World Ministries through a charity called the Pan-African Academy of Christian Surgeons. So that's a shameless plug for that, and training African doctors to do this type of work. So let's launch into the information. If you get distracted, if you're not driving, and if you're able to be at home and you want to multitask, because I know women are much better than men at doing that, feel free to go on to augs.org. That's the American Urogynecological Society. They have a couple of really helpful links. If you look for the words Voices for PFD, PFD is pelvic floor disorders. If you click on that, you'll get really helpful resources. So that's augs.org. And the other one is the uropelvicfloor.org, and that's by another organization called the International Urogynecological Association. So if you think my job is an unusual one, we have whole societies made up of people like me who do this work. And our goal is to make your life better. So if you go onto uropelvicfloor.org, that'll get you the international version of the patient resources that you can look at either now while you're listening, and that can maybe help you write your questions, or later on. And I'm going to put these 2 slides up at the end of the presentation as well. Bladder problems. Bladder problems can be all sorts of things, but what I'm focused on here is going to be the accidents. But just to briefly look at other things, we'll touch on bladder pain and bladder infections, which are UTIs, and frequency. Even if you're not having accidents, you can certainly have frequency of urine. So whenever you come to my clinic, sometimes we're called the bladder clinic, sometimes the urogynecological clinic, sometimes just the clinic where we talk about all the embarrassing problems that you're having. I'm going to be asking you, what types of accidents are you having? And that's important because your initial presentation or the patient's initial complaint will be, I leak and, or I smell, or I can't go out, can't leave the house, or I had to miss my granddaughter's wedding reception because I'm afraid of leaking, or I had an accident. And I just wanted to get fixed. And so what I'm going to ask you is, what makes you leak? I know that the leakage is the bottom line, but it's important to ask why this happens, because the treatment will depend on the cause. So stress incontinence, that first picture, is because of a weakness at the bladder neck. And so the treatment is going to be to strengthen or support that weak bladder neck. Stress incontinence probably should be called physical activity incontinence. It's not really to do with mental stress, even though it certainly causes mental stress. It's to do with that sudden movement, or the lifting of something heavy, or the cough, or the sneeze, or the jumping on the trampoline, the movement that brings stress on your bladder, and then out comes usually some small drops of urine, but it can be larger amounts. It can be a gush. So that's stress incontinence. That's a bit different from the urge incontinence, which is that problem where the whole bladder may squeeze, and the urethra, it's not primarily a weakness there, but it doesn't hold back the leakage. So the bladder can squeeze, and sometimes it's small volumes, but it can be the whole bladder can just leak right out on you. So the treatment's not going to be to strengthen that muscle, it's going to be to try to calm down that overactive muscle. So those 2 first things are the most common things, the stress incontinence and the urge incontinence, and we'll talk more about them. Overflow incontinence is the idea that your bladder is just maxed out. It's so massive and huge that a few little drops might sneak out, but you're not really in control of what's going on there. It's like carrying a bucket filled with water, and if you hit something, a few drops will come out, but you're not emptying the whole bucket. That's overflow incontinence, and that can be a neurological problem. And the treatment is going to be try to empty that bladder first before we can do anything else. Figure out why the bladder's not emptying. So we'll empty the overflowing. And number 4, the leakage can be because you just can't get to the bathroom either on time or at all. And so that can be related to how your rest of your body is functioning. And that can be mental function, the understanding or the realization of what's going on, or it can be physical, the desire to go, but you can't get there. So the treatment might be simply to clear the pathway to the toilet or bring the toilet closer. But we're going to focus on the first 2 things, which is that stress incontinence, the urge incontinence. So stress incontinence, the goal is to strengthen that bladder neck, or to support that bladder neck. The non-surgical treatments are going to be physical therapy, which is the well-known Kegel exercise, and not just Kegels, but we have women physical therapists who are specialized in working with you to not only strengthen the pelvic floor, but to also figure out, are the muscles even working at all, or can we help coordinate those muscles? So physical therapy is really important. And the pessary is a little device, I'm going to show you pictures later on, which fits into the vagina, kind of like wearing a tampon. And that just supports the bladder neck where you need that support. There's a really good trial called the Atlas trial, which compared women who were getting physical therapy with women who were getting pessary and found that both work, which is great. But the physical therapy patients were a little happier than the pessary patient. But just to reassure you, if you can't go to physical therapy or if those muscles aren't working, the pessary may work. And a lot of what we talk about for this issue is a surgical approach to strengthen that bladder neck. And I sometimes use my fist as the picture of the bladder and my pinky as the urethra. And the urethra in the female body is only about 3 or 4 centimeters long, pretty short, but it's really important. And if that's weak, whether it's from having had kids, which usually are worth it. But if you want to, you can blame them for this. If it's that's the biggest risk factor. But it's not only that. You can have genetic factors. This stretchy pelvic floor tends to run in families, or you're working out, and even if you've never had kids, every time you go running on the treadmill or trampoline, you still leak. That's just because of that weakness. So a midurethral sling is the most common way to fix this problem, to give you support. There's a picture of it at the bottom of your screen there. And usually that's made of a small strip of mesh. And mesh has been controversial. It's been around for quite a long time. And so it's not fair to say that, mesh is all the same. It's not. It started with heavy mesh, which was used for hernia repairs. And it's a polypropylene material. It's a medical grade plastic. And it works very well for hernias. But over time, since the 80s, 90s, it's definitely got a lot better. Unfortunately, initially, the mesh was not the right type of mesh, or it was too heavy for use in women, and especially in the vagina. So a lot of women were unfortunately harmed by the wrong type of mesh or the wrong surgeries to put them in. These days, after the FDA did warn against certain meshes and took some off the market, what we have now are very lightweight polypropylene mesh, and that's a picture of it down at the bottom of the screen. And there's more air in it than the actual material, and it's designed specifically for use in the vagina, and it works very well. It's the best thing we have on the market or available to treat stress urinary incontinence, and usually involves a day procedure where we use the instruments as in the screen to place the mesh behind the pubic bone or behind the groin, and it holds itself in place. And so when you cough or sneeze, you have that support where you need it. There still is a small chance that the mesh won't work well for you, or that it could cause a problem and have to be revised, but that's about 3% of women who get it these days will face that issue. And that's something that's worth talking about. If you're getting an implant like this, you need to know that even though it works well, there's still a chance it could cause a problem. If we can't use mesh, or you've had a problem with mesh, or you don't want mesh at all, we do sometimes use your own tissue, which we can take from the side of your leg or from your abdomen, and use that as the hammock or the support. I put a picture of a hammock up in the top right to give the message that this is just supporting, whether it's mesh or your own fascia. There's another less commonly used procedure called the laparoscopic birch that's been around since the 1960s originally as an open procedure, and then now we can do it using keyhole surgery using the small laparoscopic incisions. That doesn't use mesh, but it does lift up the urethra with your own tissue, and then you scar into place. And the nice thing about that is it works very well also. But when compared head to head against a mesh sling, the mesh sling was better. The other downside for the fascial slings is that we need to get the fascia from somewhere else to put it in the right spot. So it is more involved than the small, minimally invasive midurethral sling. And then lastly, there is the option of, this is really a non-surgical thing, even though it's under the surgical category, of bulking. And that just involves putting a little tiny camera into the urethra, and then putting little injections through the wall of the urethra, so the urethra squishes closed, so that when you do cough, sneeze, or jump on the trampoline, that you have that support, the ability to close. So that's the stress incontinence, leakage with coughing, sneezing, or physical activity, and treatments for that. This is the urgent continence bit. And remember, we're not trying to strengthen anything here. The problem is overactivity of the muscle. So what we're trying to do is try to calm that muscle down. So we first of all ask, are you drinking anything, eating anything, doing anything which causes the bladder to want to empty? So it varies from person to person. One of the most common things I hear when I start talking about this is, don't tell me to stop my coffee because I couldn't live without it. And that's fair. You don't need to take my advice on it. And you might find that if you stop drinking coffee, it makes no difference. So if that's the case for you, then go back to your coffee. But some people find that if you decrease your caffeine, that it makes a big difference. Artificial sweeteners, sodas, anything which is a bladder irritant. Alcohol is worth seeing if you can decrease it, and then you might find that things are a lot better. Urge suppression is this idea that is there something you can do, train your nerve again to allow your bladder to fill up, because a lot of the time since being young kids, we're told, hey, anytime we're getting in the car for more than 15 minutes, you should pee before you go, so that we don't have to stop. Or, anytime you're walking past a bathroom, just go so that you don't have an accident somewhere else. And then it sounds counterintuitive, but we tend to, if that's the pattern for you, we tend to try to encourage you to try to hold on a little longer. You're not going to cause yourself harm. And it's a matter of retraining that bladder to hold on to a bit more. And this is something the physical therapists can work with you on as well. The other thing behind this, I think, is the potty dance, where you can see little kids shaking their legs while they're waiting for the toilet, or some adults hopping around. I think there is a dignified way to do that. If you stand on your tiptoes in a dignified manner, what you're doing with that potty dance is you're stimulating the sacral nerve that runs up the back of the leg and then past the bladder on its way into the spine. So if you can stand on your tiptoes as you're waiting in that line at the grocery store or in the line at the toilet, then you might find that you can let that urge go away. So something worth trying. Second line, then we think about medications, and we're fairly quick to start thinking about this, because I know that by the time you come to our clinic, you've already done the potty dance, you've already tried to decrease the bladder irritants. So now we're talking about medications already. And there are two main groups of medications. We'll come on to those in more detail in the next couple of slides. And then if there are third line options, if the medications don't work or you have side effects, then we can go on to think of something else. But just to re-emphasize that the goal of all this is not to strengthen that bladder neck. It's to try to calm down the overactive muscle and the overactive nerve. So the first group of those medications, these are them listed on the side, and many of you may already recognize those either from having tried them yourself or seen them in your friends or relatives. They've been around for quite a long time, and they do work, but they cause some bothersome side effects. And the picture on the right there shows the main ones, which are dry eyes, dry mouth, in your bowel. They can cause constipation. And in the brain, they can make you a little more groggy, dizzy. A worst case scenario, I've never heard of hallucinations, and I guess that would be the worst case scenario. But the problem with these are, if you're over 65, we're concerned that yes, you're having urge issues with the bladder, and now we're going to start this, and we're going to cause some dizziness and grogginess at nighttime when you're on the way to the bathroom. So it's a recipe for disaster and a broken hip or some other issue there. So we're trying to avoid these medications. If you're over 65, the other issue recently is if you've been on them for a long time, like 3 years or more at high doses, we're finding that there's a slightly increased risk of dementia down the line. So I still prescribe these medications, but I'm really careful about it. We usually do it as a trial for a month or two, see if they work. If they work, maybe you might continue them for a few months or a year. But beyond that, you're wanting to get off them and get onto something else because of the side effects. These are the two medications who are the other group, and they're called beta agonists. There are only two of them in the group. Merbetrig's been around for a while, but is now starting to get overshadowed by the new kid in town, which is Gemtesa. Merbetric, the generic is mirabegron, and the generic for Gemtesa is vibegron. So these both end in egron or begron. So they're both good medications. The Merbetric has the downside of having the chance of raising your blood pressure a little bit. So if your blood pressure is out of control already, we're definitely not going to start this. If you're on some medications for blood pressure and it's well controlled, you can still take this. We just have to be careful. The downside of Gemtesa is the cost of it. And it's probably the best medication for this problem, and the company knows it. So hopefully the price will come down in time. But these are the alternatives to the older medications. If you can't, or if they don't work, or if they have side effects, then we're thinking about these so-called advanced or third-line therapies. And bladder Botox is a tried and tested way of going in between that overactive nerve and the overactive muscle. So just to repeat, this is a nerve issue where the nerves are usually overactive, and the bladder has the ability to fill automatically and not have to keep telling you all the time, and to empty automatically. And you have these automatic nerves, just like the lungs or the intestines or the heart. You don't have to think about your heart beating. You shouldn't have to think about your bladder filling and emptying. But the nice thing is we do have the ability to change that with our voluntary conscious nerves too. But where these act is at the subconscious automatic nerves. It gets into the place where the nerve and the muscle meet, and it just helps that overactive muscle to calm down. And they both work very well. The bladder Botox has the advantage of being no incisions. It's done in the office. We numb up the bladder with a solution beforehand, and then it takes maybe 5 minutes to put the injections in, and then you go home. There's no downtime. There's no surgery. The only downsides are you have to get it redone every 6 to 9 months because it wears off, and if it works so well, you might not empty your bladder all the way, and that leads to a risk of infection, bladder infection. About 1/3 of women who get this in the first month, and in some women, about 3% who get the 100-unit dose, you might have the risk of having to learn how to catheterize yourself temporarily until it wears off. So when I say that, most women say, no thanks. But just to reassure you, if that is what you're heading for, there's a 97% chance you won't have to do anything with a catheter. So the odds are in your favor. Sacral neuromodulation is also tried and tested. It's not new. It's been around for a couple of decades. But in the last couple of years, the companies that make this have really brought out versions which are excellent. They work well. The battery in the Medtronic one that we use lasts 10 to 15 years. And that's one of the big advantages of sacral neuromodulation over the bladder Botox, is the longevity. If that battery lasts 10 to 15 years and we put it in the stimulator in the right place, you're going to get really good relief long term. Downside of this is it is a surgical option. It's really the only downside though, and it is a minor surgical procedure. It's done in 2 steps. The first step is to put a temporary test wire in through the sacrum. In this picture, you see a woman turned sideways, and the sacrum is the bit just above the coccyx. It's the tailbone, and you've got little holes in that where the nerves go through after they've left the spine already. So it's not a nerve stimulator that goes in the spine. We don't do those. Other people do. This is like those, but it's going through the hole in the tailbone to sit beside the nerve, which goes to the bladder and to your rectum. And that nerve, remember, is overactive. So the way this works is the battery gives a really tiny but continuous stimulation to the nerve. and it interrupts all those overactive messages going to the brain and the overactive messages going back, so that you go less frequently to the bathroom and you have fewer urge accidents. So it works for 90% of women who get the test. The test is done in the office, and then we take you to the operating room, put the battery in, small incision. You don't have to be put to sleep for it. You just get some sedation. So two really good options. And there are a couple of other um, ways to stimulate that nerve through an ankle stimulator, which we also offer, something called eCoin. The battery is inserted into the nerve that runs up the back of the leg. But these are the main two we're offering right now, both of which work really well. Just to briefly touch on bladder accidents and bladder infections. These are more common after the menopause. It's related to estrogen or lack of estrogen. There are associations that can be potentially modified. So there can be associations with intercourse, with prolapse of the pelvic organs. If you're not emptying your bladder all the way, and there's a reservoir there of urine just sitting there that allows bacteria to grow. If you have kidney stones or bladder stones, then those are places where the bacteria can live and hard to get rid of. So there may be something going on there that can be changed. But prevention is really a very important part of dealing with bladder infections. And keeping well or adequately hydrated, not overdoing it, but getting your adequate hydration. Sometimes we say 8 cups of water a day, but depending on your age, you may not need that quite that much. And if you're working out a lot and sweating a lot, you'll need more. But getting enough hydration is important. After the menopause, we often talk about a little bit of topical estrogen, which you can apply yourself at home. We prescribe it, and you get a little tube of it, and you can insert a pea-sized amount on the fingertip twice a week, just on the inside of the vagina, and that helps the blood supply to the urethra. And if you can help the blood supply to the urethra, that's important to prevent bacteria from getting up into the bladder and causing infections. So it's an evidence-based, and well-known, and safe way of preventing infections. Twice a week, low-dose topical estrogen. It doesn't cause breast cancer. It doesn't cause strokes. It's not systemic. It's just a small dose locally. And we use it even on women who have had a personal history of breast cancer, knowing that it doesn't have an association with that. And then D-Manos you can buy on Amazon.com. If you're a Prime subscriber, that's, I think, the best way to get it. You can certainly pay a lot more elsewhere at a health food store or at the pharmacy. It's an over-the-counter pill that you can take and add onto your daily routine. If you go on Amazon.com and plug in D-Manos, you'll find that the Amazon favorites will be a 1,300 milligram dose of it. There's, by the way, no consensus as to the best dose of D-Manos. You'll find 500, 1,000, 2,000. But for 1,300 milligrams, you can get, I think it's 100 pills for $15. So you're talking about a $50 a year way to prevent bladder infections. That's the idea behind that. Is it just helps flush through the bacteria. The bacteria can't latch on the sidewall of the bladder. Let's move on to prolapse problems, and I'll keep track of time. I want to give you guys enough time to ask me some questions. So this is focused on accidents. So we're talking about bladder accidents. I want to mention bowel accidents as well, but just to briefly run through prolapse problems, because there is a strong association with this and bladders not working. This can be bladder prolapsing. Rectocele is not the rectal prolapse. That's different. That's at the bottom. Rectocele is actually vaginal prolapse. There can be a pocket of the rectum hiding in that. Uterine prolapse, or if the uterus is not there, it can be vaginal vault. Think of vaulted ceilings. The top of the vagina should be well supported, but if the structures aren't there, that vaulted ceiling's gonna collapse, and you can end up having the top of the vagina come through the birth canal and like inverting a sock, and you end up losing that support. If you have prolapse, usually you can just watch and wait, and that's what a lot of women do until the prolapse starts to become more bothersome and impacting your quality of life. And you can do pelvic floor physical therapy as well for this. Those are complex, very important. So meeting with a physical therapist if you have prolapse is a great idea. There are also options for doing physical therapy at home. One company that I've recommended, because my patients recommended it to me, is PeriFit, PERIFIT. It's a French company. They make a device that gets inserted, that you insert at home into the vagina. It connects to your smartphone so that you can play a game on it where you make a butterfly go up over a flower, and then you relax the pelvic floor muscle, the butterfly goes down, then keep doing it. So it can take some of the monotony of Kegels out and make it, I wouldn't say fun, but it can make it at least somewhat interesting. Pessaries, I mentioned those earlier in the presentation as a way of helping to support the bladder neck for stress incontinence, but they can also be used and are mainly used to support the vagina to prevent prolapse. And these are silicone rings or various shapes and sizes. The top one's a donut shape, as the name implies. You can see why. And these can be inserted yourself. You can like a device, like a menstrual cup or a diaphragm or tampon, or you can, if you don't feel comfortable with that, we in our office with our staff can help you manage this. You come in every 3 to 6 months. We can take it out, make sure that it's not causing any problems, and then put it back in again. If managed at home, you can clean them with soap and water and just manage it yourself. The goal is to find your size that fits comfortably and that holds everything up. And then, of course, there's surgery. I'm not going to go into great detail here, but just to briefly summarize, surgery for prolapse, which is a little different than surgery for continence, but is related. You can use your own ligaments. Sometimes we call that a uterosacral ligament suspension or sacral spinous ligament suspension. If those don't work or it's not an option for you, then we use mesh. Again, it's polypropylene, same material as what we use for stress incontinence. We just anchor it to a different place. And both of those options, what they do is they restore the anatomy. They're restorative repairs. The third one is not a restorative repair. It's simply to narrow the birth canal, the vagina itself, so that the prolapse doesn't come down. And the downside of that is that intercourse is not possible after that. So depending on what your goal is, there are really good minimally invasive options for treating prolapse. So let's jump into bowel problems. And that's not a sentence I say often, but bowel problems can be accidental bowel leakage, urgency of the bowels, or trouble emptying your bowels. All of this are the exciting things that we talk about in my office. So factors for fecal frustrations, you can have consistency of stool problems, and we might work alongside gastroenterology with that. So your GI doc might refer you to us, or we might refer you back to them. And we're working on this world famous Bristol stool chart. I've never been to Bristol in England yet, but this is what they're known for. They're known for the chart that helps describe the consistency of stool. And a lot of fecal accidents and continence is related to this. So we spent quite a bit of time looking at, is there anything you're eating, drinking, which is stimulating the bowels or causing these issues? Coffee, tea, again. I'm not going to force you to stop drinking your coffee, but you may have already noticed that after your coffee, you might want to have a bowel movement. So there's a connection there. Certain foods, lactose, potentially specific sugars, medications, of course, big time antibiotics, and other medications which have the side effect of causing looser stool. You may not be able to stop those medications. So how can we help you with your stool consistency? And we can. And then supplements. Sometimes things that you feel are doing you good may be interrupting your ability to hold your stool. We spend a lot of time talking about fiber as well. So consistency of stool, sphincter damage. From the picture on the bottom there is a picture of forceps, the jaws of life, but they can also disrupt the muscle of the sphincter, or whether that's trauma or prior surgery on the bowel, on the sphincter. Nerves not working. There are quite a few. Diabetes can affect the nerves, spinal cord injuries, of course, and spinal stenosis and other Issues with disc prolapse can impact your fecal continence, and there are other things, congenital disorders, and so on. So, just like you're having accidents with the bowels, just like you're having accidents with the bladder, it's important to know why you're having those so that we can get to the treatment, because the treatment's going to depend on the cause. So I mentioned we talk a lot about your diet, adding fiber, and this sounds counterintuitive to a lot of women, but if you add fiber, you don't necessarily, in all cases, cause your stools to become more loose. The goal actually of adding fiber for folks who have loose stool is not to make it more loose, but to bulk it up. So depending on the type of fiber, um, by the way, whole foods and dietary fiber is going to be the best fiber because you're going to get a few different types of fiber in that, and that's going to be also vitamins are good for you. But we can add fiber supplements like Citracel and Metamucil and psyllium husk and fiber gummies even. There are lots of tasty, not so bad ways to get fiber into your diet. And a confession that we can make is that we probably don't get, on average, enough fiber in our diet. We probably get about half. The American diet, on average, contains half of the recommended daily fiber supplements, which is 25 grams for a woman. So if you have a look at the back of whatever you're eating, if it contains the diet fiber, have a look at that and see if you're getting your 25 grams a day. And if not, think about a supplement. If the stools are loose and you've tried fiber and it's still not working, and you've tried switching medications or whatever, and you still have loose stool, loperamide or also known as Imodium, is something that you'll see at the airport as folks get on planes to help prevent you having an accident on the plane. And if you read the packet, it'll say you can take 4 of them a day. But what you can do instead of taking 4 and blasting it is you can just take 1 a day on a regular basis. And you can take half a pill a day if you find that you're very sensitive to 1 pill a day. And this is for fecal incontinence in the setting of loose stool. You can take this, and this has been shown to help. There's a good study called the Capable trial, which looked at diet and fiber and loperamide, physical therapy, found that all of them can help. And there may not be huge differences between all of these, but if all of them work, then you may end up trying all of them for this. And physical therapy, again, it's a really complex, important muscle and an incredibly important ability to tell the difference between gas and water and hard stool. And your body should be able to do that. And physical therapy can help get that muscle, get that nerve working better again. So that might involve a pretty intimate exam as well as the pelvic floor physical therapy. But having biofeedback or having something placed in your bottom is not your idea of going for a pleasant physical therapy. It's not like going to get your knee or your shoulders looked at. But it's really important that you develop a good connection with a qualified physical therapist who specializes in this, and they can make a huge difference to your life. Finally, sacral neuromodulation. I've already mentioned it because it treats urge urinary incontinence, but I briefly mentioned that it goes to the rectum nerves as well, and that's why it's on here. I'm not just repeating myself. It really is a good treatment for both urge urinary incontinence and for urgency bowel incontinence, and has leapfrogged over the other procedures, which I haven't even listed here. For example, surgery to put the muscle back together of the sphincter, or a colostomy bag. It's not even on the list right now because sacral neuromodulation has really transformed the ability to help women with fecal incontinence. Briefly, just at the end, all of these are connected with intimacy and sexual function. Prolapse can get in the way. Pain can be a big issue. Loss of self-esteem. If you are having accidents, especially in connection with intercourse, and that's something that tends to be the last thing that women mention when we're talking in the office. But this is really important. And so, if one of your goals is to help restore this part of your life, that's something that we can definitely talk about and address. And this is important to treat the whole person. My focus tends to be on restoring the anatomy and the physical aspect of things, Where I can't help with the mind and the muscles, I'll refer to physical therapists, and we have folks who are, get counselling in how to deal with couples therapy. So, if those things are needed, I'll encourage you to look into that, so that we make sure we're treating the whole person. Just to briefly give you those resources again, here they are: augs.org and yourpelvicfloor.org. That's augs.org. If you missed it at the beginning, really good resources there, and yourpelvicfloor.org. And if you are struggling with these issues, please feel free to reach out to your primary care doctor or your OBGYN, or these are our direct numbers, our direct lines. I'm working with a nurse practitioner called Valerie Fritton, and a urologist who's a urogynecologist, trained urologist, called Dr. Janet Thompson. So the three of us are the primary providers in the urogynecology with Trinity Health. But we have also a great staff of medical assistants and nurses who would be happy to hear you and connect you with us, and to get the ball rolling on making your life better, which is our goal. Thanks for your time, and I'm going to ask for help in reading out the questions, and hopefully we can get to a few of those in the next 10 minutes.
Yes, thank you, Dr. Shaw. As a reminder, you can submit your questions using the Q&A chat feature, which is found near the bottom right of your screen. With that being said, we'll go ahead and kick off our Q&A session with the first question. So, Dr. Shaw, we had a question come in asking, what do you recommend as far as prevention for prolapse for young mothers who are planning for more pregnancies, who already have some bladder leakage when sneezing and coughing?
So I love that question. I think you're in good company if you're asking that question. Young moms who already are experiencing these issues but wanting to still have more kids is great. All in favor of big families or bigger families. There are some options which are, I would recommend, non-surgical options initially. At the physical therapy is the first place I would recommend going. There may have been damage to the muscles during delivery, so or there will have been. So working with them is a great idea. And then if you're young, physically active, I have quite a few women who prefer to use a pessary with working out or with exercise. And some younger women say, I don't want that because that's what my granny had. But I think to just reassure you that there are women of all ages who use pessaries, and you can use them when you're being really physically active and take them out at the end. So there are some good non-surgical options for that. So I would recommend that. I would not usually recommend going for a surgery prior to having another kid. And if you were to do that, then I would probably consider a laparoscopic birch, which is a non-mesh option for that. And occasionally we do that. We do surgery on someone who is still going to have more kids. It's a pro-con decision. The benefit for you is if multiple years of having better quality of life and bladder control or bowel control, then absolutely we'll consider doing surgery, even if you're planning future kids. I see a couple more questions. Just briefly, the beta-3 agonists are not anticholinergic medications. That is correct. They are not anticholinergic medications, so they won't have those side effects. The beta-3 agonists are just different from anticholinergics. And another question is, I have a neurogenic bladder due to a brain injury. Is neurogenic bladder a disability? It's very much connected. Is it a disability? I think it is a disability. It's impacting your quality of life, and neurogenic bladder is a major condition in itself. So yes to that. Another person says, I'm on Gemtita and I've been on different medications for years. Don't have side effects, but should I be concerned that I've been on medication so long? Not for Gemtisa or Myrbetriq. They're not aware of any downsides to being on the beta-3 agonists long term. Unlike the anticholinergics, where there is now a concern that if you've been on them for a really long time, at high doses, and in the study that I'm thinking of, it was 3 years. There was a slight increased risk. That it's not to say that if you've been on anticholinergics, you're going to get dementia. That's not the case at all. There was just a slight increased risk of having dementia if you've been on anticholinergics long term. So if you're on Gemtesa and you're getting benefit from it, then that's great. You can continue on indefinitely. I see, does the sacral device get inserted in the same place for both types of incontinence? And the answer to that is yes. It's the third sacral foramen, third one down from where the tailbone starts. And it's because the nerves to the bladder and to the rectum are right there. And there is certainly some other nerves from the second foramen and from the fourth foramen coming after they've come out of the spine there. But S3, sacral space, sacral foramen 3 is where it gets placed for both urinary and fecal incontinence. Someone else says, I had a bladder sling and it worked for 6 years and now it's failing. Can it be redone? I'm 76 years old. We would have to meet, we would have to talk and see what you mean by failing, because it may be that you're having some urgency and urgent incontinence. And if that's the case, the sling could still be working, but we can fix the urgent incontinence or focus on that. On the other hand, absolutely, it may be that the sling has moved or it's no longer working. Can it be redone? That particular sling can't be redone, or it's not easy to tighten that, but there are instances where we would either do another sling or consider doing bulking or another procedure. So yes is the answer to that question. Another question, if someone has went through testing with another urologist or urogynecologist, would you be able to perform surgery or require your own testing? So yes, I would look at their notes, and I don't necessarily need to repeat everything. But I would usually repeat an exam, or I would do surgery on anybody. Do you know how far out your office is booking? I think we're about a month out for seeing patients in the clinic, and about 6 weeks out for doing surgery. But I would defer to our surgery scheduler on that, and instead of getting her in trouble, please be kind to her. She's a wonderful person. If you're keen to have surgery soon. What is the remedy for needing to get up in the night to urinate? That's another, it's a really good question. But I think, again, we need to look at what are your drinking patterns at night? What are your other medical comorbidities? Do you have sleep apnea? Because sleep apnea is related to having to get up more at night. So if we treat the sleep apnea, a lot of the time patients say, my nighttime peeing got better. So we need to ask, why are you making more pee at night? Why are your kidneys overactive at night? There are some ways that we can improve on that. And the medications may also help that if the other things haven't worked. Question, this is a really good one. Can you have both stress and urgent incontinence? The answer is yes. Sometimes we take a shortcut and call that mixed incontinence. So you can definitely have both. And if you have both, I usually ask, which is worse, the stress or the urge? Because whatever's worse, we'll go after that first, and we'll remember that the other still is there. And then once we've treated one, then we'll come back and address the other. I had a C-section 5 months ago. I feel my bladder is full, but I just empty little. Do I have a problem? The nerves, if you had it depends what the delivery by C-section was for. If you were in labor for a while and those nerves and muscles already were stretched or even injured by the baby's head pressing on them, you could still have some nerve which is recovering. C-section also is a fairly big surgery, so your bladder can be impacted by that. So what I would recommend is making sure that you are emptying your bladder adequately. And that can be done with a visit to the clinic where we do a little ultrasound or an in and out catheter after you've been in the bathroom, and then we make sure that you are emptying. So yes, there may be a problem there, but things can be certainly very different, even for the first year after having a baby, whether it's by C-section or by vaginal delivery, and hopefully you make a full recovery from that. I hope you sleep well tonight with the 5-month-old. Will we get these slides sent to us after the lecture? I think the answer to that is their recording will be available. So not the slides, but the slides through the recording. How would you know if you've had a Prolapse is diagnosed by a physician. So usually prolapse, you feel a sensation of a bulge in the vagina. Some people say it's like laying an egg if it's really large. Some folks can feel tissue when wiping. So it's usually something you start to feel, and then officially it's diagnosed by usually your gynecologist. But your primary care doctor, if they're doing pelvic exams frequently, they can be really astute at diagnosing it and the stage that it's at. Is there any relationship between dementia and prolapse? Not that I'm aware of, but there is a relationship between dementia and urge urinary incontinence. So bladder issues and dementia are definitely related. I have a bladder and rectal prolapse. I believe they're called stage 3. My main problem is not being able to fully empty my bowels. I feel like I need to empty my bowels several times a day. I usually use a squatty potty. I've done PT. What are the other things available to help me? The pessary can make a difference with the bowel prolapse, which sounds like rectocele. So the rectocele can be fixed or improved by the pessary, and then you might get some relief. But otherwise, for this problem, if you have a little rectocele there, often you may not get significant relief until we do a rectocele repair. But you're doing the right things with the squatty potty, fiber as well. I would need to mention that. Do you ever prescribe a prophylactic for someone who has recurring UTIs? Yes, occasionally we do. Usually we do try the topical estrogen and the D-manos. We make sure you're emptying your bladder well, see if there's any other reason for the bladder infections. But if we've tried everything else and you're still having these breakthrough infections, then yes, occasionally we do a preventative antibiotic. We have to be careful about which ones to avoid the long-term downsides and side effects. But yes, is the answer to that. Is there ever lower back pain associated with this condition? You're talking about prolapse. Yes, or even rectal prolapse. Yes, there tends to be a tugging lower back ache that can go along with it. Maybe that's associated with the stretching of the ligaments. However, lower back pain can have so many different causes that I wouldn't want to say for sure that your lower back pain is definitely associated with prolapse. And could past treatment with radiation therapy for uterine cancer affect the chance of positive outcomes for bowel or bladder incontinence? Absolutely. Radiation is really important, is good treatment for cancer. And I'm glad that if you're writing this, it means so far the radiation therapy is working for your uterine cancer. But radiation has a major impact on your blood supply to your bowels and to your bladder. So long-term has some really big downsides, including decreasing the compliance of your bladder and leading to accidents with the bladder and the bowels. But does it affect the chance of positive outcomes of the treatments? Yes, it probably means the treatments aren't going to be as likely to work quite as well. But that doesn't mean they won't work at all. So it's still worth seeing you and getting the treatment that you need. And then probably lastly, or the last two questions, we should probably stop with the question there at 7:53. What if you already had surgery for prolapse, cystic field and rectal 20 years ago with a sling? Now you're having bladder leakage a small amount every day. 20 years ago, a lot can change. A lot of anatomical things can change over that time. It's good that the potential has lasted that long, but I would just start from scratch. Knowing that you've had these in the past is important, but I would look at how things are now. And if you're having leakage at this point, just reevaluate and see what's causing it. Usually there's a way, even though you've had those procedures in the past, usually there are some things that can be done to improve. And then lastly, if you're a person who has held their urine or have a strong bladder their whole life, and that caused damage to the bladder by those habits, and I would say no. And that's going against a lot of the conventional wisdom. And so I know I'm offending some people by saying that, but your body has the ability, if everything's working well, to tell you, I am too full. I just need to empty. And so when you listen to your body, and even if you hold on to it longer than you feel like you would comfortably hold on to it, you're not going to damage your kidneys or your bladder if you hold on to it for a little longer than comfortable. Your body increases in discomfort until you just eventually go to the bathroom, and then your bladder relaxes. So I would say no. I think that if you have a strong bladder, think of that as a blessing. Sometimes we do joke about a nurse's bladder or a teacher's bladder, but I would say you probably don't feel guilty for holding on. If you've been able to do that all your life, that's not likely to be causing your bladder problems now. Thank you all very much for these questions and your interaction through that. I look forward to meeting you in person if we're able to do that. And please reach out to our offices. If you don't want to see me, I have two wonderful people I work with, Valerie Fritton and Dr. Janet Thompson. They would be happy to see you as well. So please don't hesitate to reach out. Thank you.
Thank you once again to Dr. Shaw for a wonderful presentation and Q&A session. Our next Wednesday Wellness topic will be on Wednesday, December 13th at 12 p.m. and we'll be discussing mental health during the holidays. A link to register will be included in our follow-up email that will be sent over the next few days. Thank you again for joining us, and we hope you have a wonderful rest of your evening.